Hello, everybody. Welcome to Inside Endometriosis Surgery, What Patients Want to Know. So I'm Dr. Lee Christianson with La Miranda Gynecology and Surgery, and I would like to welcome everyone here. Thanks for tuning in, and we're going to go ahead and get started with our presentation. So, all right. So our objectives for the talk today are to define endometriosis and review associated symptoms and what the diagnostic evaluation is, and what the indications are to undergo surgery, the difference in surgical techniques, and what the risks and benefits of surgery are, and also what to expect post-op. And just a disclaimer, this presentation today is for educational purposes and should not take the place of personalized guidance by your own physician. So what is endometriosis? So it's the presence of endometrium, the uterine lining tissue, outside of the uterus. And the estimated prevalence is about 10%, although we think it is quite likely higher. Many people may not know that they have it. And in the setting of infertility, we actually find it up to 50% of the time, and even higher, 70 to 80% in the setting of chronic pelvic pain. And what causes endometriosis? So we actually don't know. There are several theories that we're not going to delve in too much today, but those include retrograde menstruation, actually being born with this tissue already outside of the uterus, or that it is like coming from other places in the body, or that there's some dysregulation of the immune system is also another part of the discussion. And we think there is some genetic predisposition, not necessarily identified one gene that causes it, but we do see if you have a first-degree relative, like a mother or a sister that have endometriosis, you actually have a 7 to 10 times increased risk of developing it yourself. And we think it's probably a combination of environment and also genetics. And this diagram just basically shows kind of the different areas that we can see endometriosis. So most commonly we see it in the pelvis. So this shows the uterus and ovaries and fallopian tubes. This is kind of the view that we get looking at the pelvis from, let's say, a camera in the belly button. And we can see these little implants can be scattered in various places, either on the surface of your gynecologic organs or on the surface of other organs that are nearby. So what are the symptoms? So dysmenorrhea, which is just the fancy way of saying painful periods, that is probably the hallmark most common symptom that we see. Also deep dyspareunia, and that means painful sex. And this usually is worse during the luteal phase, which is the weeks leading up to your period, and then also during the period. Also, we can see dysuria, which is painful urination, dyschezia, which is painful bowel movements, also closer to the time that your period occurs, chronic pelvic pain, fatigue, and issues with fertility. So interestingly, some people have no symptoms, no pain, but actually get this diagnosis because they're unable to get pregnant. So the average delay in diagnosis from like the onset to symptoms to actually having your diagnosis of endometriosis is on average 7 years. We think somewhere between 5 and 12 years for most people. And as part of kind of the full evaluation, the first very important thing is taking a thorough history, what we call a menstrual history, which is discussing periods and symptoms. And for many people, just kind of hearing their story, I can tell that there's either like a very high or a very, very low likelihood that they have endometriosis. Imaging is often part of the next step. Usually first a pelvic ultrasound, and I would say pelvic ultrasound will sometimes pick up endometriosis, but often it will not. So if on ultrasound you have an endometrioma, which is basically a cyst on the ovary from endometriosis that is filled with blood, that is something we can easily detect on the ultrasound, which is what the picture is showing on this slide. but there are many individuals who do not have an endometrioma. Pelvic MRI is a little bit better, but it is still not perfect at detecting very small implants of endometriosis. So surgery, particularly doing a laparoscopy with biopsy, has for a long time been the gold standard to diagnose it. And basically under the slide, we see uterus lining tissue, often inflammation, where it's not supposed to be. So what are the reasons to do surgery? Typically, it would be ongoing symptoms and really like the diagnosis is unclear. So anyone with really chronic abdominal and pelvic symptoms, we think possibly they have endometriosis, but not sure. A laparoscopy can definitely help us figure it out. Or maybe someone, we do suspect they have endometriosis, but they're just having persistent and worsening pain despite lifestyle changes and medical therapy. That would be another reason to do surgery. Or infertility. So surgery is typically done from a laparoscopic approach. This has really become standard practice for endometriosis surgery, which is minimally invasive. It usually requires anywhere from 3 to 5 small incisions, typically about 5 to 8 millimeters in size. And with any laparoscopy, the abdomen is distended with CO2 gas, and this allows us to see inside the abdomen. And for pelvic surgery, we always place people in what's called Trendelenburg position, which is where the head is lower than the feet. And that's so your intestines and other organs kind of move towards your head so we can see better in the pelvis. And so this type of endometriosis surgery, it is often done with robotic assistance. That's what I do in my practice. And this picture is showing the Da Vinci robotic surgical system, which is what most endometriosis surgeons are using. So with the robotic system, it doesn't do anything on its own. Basically, the surgeon sits at this control panel, and here they have the robot by the bedside, and basically it will attach to the laparoscopic ports, and the robotic instruments have the ability to move in a 360-degree fashion, like similar to the way that our hands move. And so it translates the surgeon's hand motions into this small robotic instrument. So it allows for a much more detailed dissection compared to like traditional conventional laparoscopy. And also the camera that we use for robotic surgery is much higher resolution. It also has 2 eyes, so it allows more of a 3D look at tissue compared to conventional laparoscopy. So the next part is surgeon selection. And any board certified OB-GYN is going to be trained in pelvic laparoscopy. They're going to be able to do a diagnostic laparoscopy, look inside the pelvis, and diagnose if you have endometriosis or not. However, many general OB-GYNs may not have extensive training in the excision of endometriosis lesions. And so for that reason, if you're considering endometriosis surgery, I would encourage you to look for a board-certified OB-GYN that has also completed a fellowship in complex benign gynecology. This was formerly called MIGS, minimally invasive gynecologic surgery. And so these individuals have done advanced surgical training in endometriosis excision. This fellowship has probably been around like about 30 years or so at this point. So there are still some grandfathers of endometriosis surgery that really maybe haven't done a fellowship but are very skilled in endometriosis surgery. So what about surgical techniques? This is like a very common question that I get in my clinic all the time. The ablation versus excision. And so ablation is a technique where tissue is destroyed with electrosurgery or a laser. And this is likely effective for very superficial and small lesions. And it's also useful in areas where excision is not possible. Like when we see endometriosis kind of stuck on the surface of the uterus and we're not planning hysterectomy, or on the surface of the ovary that is very superficial. This is different than excision. Excision requires more surgical training because often deeper dissection in what we call the retroperitoneal space is required. And This is more effective treatment for deep infiltrating endometriosis. So endometriosis that is more just surface level, it goes into the tissue underneath it. And so if you do ablation on an area of deep infiltrating endometriosis, you're probably just like burning the surface of it and really not treating what's underneath. Also for endometriomas, there is some research that doing excision is more beneficial than just draining the cyst and doing some ablation of the inside. So endometriosis can look all different ways at the time of laparoscopy. These pictures are from a New England Journal of Medicine article on endometriosis. And it's basically showing that it can look like small little superficial peritoneal lesions that could be various colors: clear, yellow, red, brown, blue, black. They can be various locations. The endometrioma is that cyst on the ovary, which is shown in picture D. And then we can also start to see that pelvic organs get really stuck together with endometriosis, which is seen in that top picture B. So there are some special circumstances that are important to know about for surgery. So one is any presence of deep infiltrating endometriosis that is involving surrounding organs. And I would say the two organ systems that we see most often involved are the GI tract, particularly the colon, or the urinary tract. And so with the colon, if we suspect there is endometriosis involved, oftentimes you'll need a preoperative MRI and a colonoscopy. The colonoscopy is basically to look and see if endometriosis has grown all the way through the wall of the colon to the lumen, to the inside. And oftentimes you will need a consultation with a bowel surgeon and possibly a combined surgical case with a bowel resection. The urinary tract is the other frequent area we see involved. You would also have a preoperative MRI to assess this, to assess the bladder and the ureters, which are little tubes that carry the urine from the kidneys down to the bladder and typically run right past the gynecologic organs. If we suspect there's some urinary tract involvement, I may recommend consultation with a urologist and possibly a combined case with ureteral catheter placement, which are basically little tubes that go through the ureters that just help us better identify them during surgery. So what are the benefits of surgery? So number one is pain. And most people that undergo endometriosis surgery experience significant pain improvement. About 50 to 95% of people report better pain at 1 year after surgery. For severe endometriosis, usually pain decreases by around 50%. However, results vary based on the type and severity of endometriosis. Fertility is also another endpoint for surgery. So surgery can improve your chances of getting pregnant. Overall, post-op pregnancy rates range from 57 to 70% in the first year, and the best chance of getting pregnant is typically in like the 3 to 6 month range after surgery. So what are the risks, right? Because we're talking about a lot of the benefits. It may seem like a great idea for surgery, but there's always risks. So any type of surgery, always a risk of bleeding, always a risk of infection. Overall, those are very minimal with this type of surgery. And then always risk of damage to surrounding structures in the pelvis, like the GI tract, the urinary tract, nearby blood vessels or nerves. In general, injury to these things is very rare to happen, but we know with endometriosis, because it can distort some of the pelvic anatomy, the risk of injury is a little higher than for compared to other types of gynecologic surgery. There are also risks that go along with general anesthesia. A risk that your endometriosis may not be completely resected, that your pain may not improve, or you might get worsening of chronic pain. And then there's also important fertility considerations if you're thinking about surgery. So any surgery on ovarian cysts may affect your egg supply. And so if fertility is a goal, I would definitely consider a consultation with an REI who's an infertility specialist, physician, before surgery, as IVF or an egg retrieval, it might be a better first option than surgery, particularly if you're over the age of 35, you already know that you have a low egg reserve, or there's maybe some other factor of infertility at play. So anytime you're thinking about surgery, very important to have realistic expectations. And surgery is not a cure for endometriosis. There is a high likelihood of recurrence. About 40 to 45% of people will have some recurrence of pain, and 15 to 20% may have a repeat surgery within 2 years, and 50% within 5 to 7 years. And we know that going on to medical therapy after surgery does reduce the risk of a recurrence happening. And it's also very important to know that repeat surgery for endometriosis has limited effectiveness for both pain and fertility compared to the initial surgery. So the greatest benefit we usually see is with that first surgery. So what is recovery like? Typically, you are discharged the same day with a laparoscopy. I would say only in the event of like a much bigger surgery or maybe a bowel resection would you be staying overnight. You're up walking in recovery and doing short distances immediately. And I typically recommend that my patients plan for 2 to 3 weeks of recovery time from their usual activities. And if you're working, it kind of depends on like the nature of your job, if it's something you could go back to, after a week, or if you would need like a full 3 weeks of recovery, depending on how physical your job is. So you should avoid really any super strenuous activity for 4 to 6 weeks. And that's to allow the abdominal wall healing so you don't get a hernia. And then post-operative pain typically is primarily managed with ibuprofen and acetaminophen. Oftentimes I'll prescribe a small amount of opioids like oxycodone for the first couple days for breakthrough pain, but some people don't actually need any oxycodone. So questions to ask your surgeon. What type of endometriosis do I have if we know that you have it? Will you use excision, ablation, or both, like a combination? And what are my specific risks? And are there any special preoperative testing required? And what medications will I need after surgery? So important to talk about not just pain control immediately after surgery, but also in what is the long-term plan, if any, for some hormonal suppression. And then what are my options if symptoms return? So surgery is never the endpoint. There's always like a long-term management plan needed for endometriosis. So a little bit about me and La Miranda Gynecology and Surgery. So I'm board certified OB-GYN. I have a focused practice designation in minimally invasive gynecologic surgery. So I did a fellowship training. And I'm also board certified in lifestyle medicine. So that is a huge part of my practice as well. And when you come to our clinic for an endometriosis consult, I typically will spend an hour with you. We do a comprehensive assessment of symptoms, a physical exam, talk about different lifestyle counseling, medication management options, surgical options. And then if we need to involve any additional services like the specialist that I talked about, we need to refer you for imaging or pelvic physical therapy. Those are all things that we do from our clinic. Okay, I'm happy to take any questions. And if you have access to the chat, I think you can just put them in there. So how do I explain this decision to family members who don't understand how serious my pain is? So this is very common. I often encourage that my patients bring their family members in either for a consultation or for one of the visits, just so they can hear our discussion about symptoms, how real endometriosis is, what I anticipate to find. And I think that for many of my patients, that's been helpful to have their family member there kind of listening. And I've had several patients tell me I brought this person so that they would understand what's going on. So I think that for many people in the United States, you should be able to find a specialist if you're in a major metropolitan area. This fellowship training is getting more and more prevalent, and so there's more of us out there. So if you live in a very rural area, you may have to travel, but I do think that it is worth it if you're able to do so. Yeah, so should I consider freezing my eggs before surgery? So the kind of short answer is maybe. I would say it depends on the extent of the endometriosis that we anticipate. So if on imaging we see really big endometriomas on both the ovaries, and we know that doing surgery is going to impact them, it may be a consideration. I would say egg freezing is obviously a financial cost for anyone that's considering it. And then I think age is also a factor as well. So for all of us, our egg reserve is declining as we get older. And over 35, that starts to be more rapid. And I think, if you're kind of unsure, even after a discussion with an endometriosis specialist, it is really helpful to have a discussion with an infertility doctor before going forward with surgery. In general, a patient has stage 4 endometriosis, is there still potential for fertility help with surgery? So to a certain extent, there is, and I would say not all stage 4 endometriosis is the same. So the stages that we do are basically determined on how much we see at the time of surgery and how many different areas are impacted. And so some people have a much greater impact to their fallopian tube and their ovaries compared to others. And many people with stage 4, if they're already struggling with infertility, maybe really just be looking at IVF. And so we do know that there is some benefit for IVF success to still surgically treat stage 4 endometriosis. But also this is another opportunity to have kind of a multidisciplinary discussion with a fertility specialist to see what's going to be the optimal way to protect your egg reserve and meet the pregnancy goals. So there is research. So the question is, do I need to stay on medication after surgery to prevent it from returning? So there is research that there's a lower rates of recurrence if you go on some hormonal suppression after surgery. So I typically, for people that aren't trying to get pregnant immediately, because a lot of these hormonal medications you cannot take while you're trying for pregnancy, I do recommend many of my patients go on some suppression afterwards to help prevent recurrence. Yes, and there's a lot of different options, and so we tend to have a discussion to figure out what is the best approach. So this question, what exactly do you do during endometriosis surgery? Are you removing it or just burning it? So that kind of went back to my slide about the ablation versus the excision. So typically in my practice, I'm excising everything that I can. The only things that I'm really doing ablation on are things that really can't be excised. Like if I see a little, like let's say we're not planning a hysterectomy, someone's planning pregnancy in the future, and I see a little superficial spot of endometriosis on the surface of the uterus. Really the only way to excise that is to start cutting into your uterus. Usually those are superficial, and I'm gonna do some ablation. Or if it's like a very superficial implant on the ovary, not one that's created an endometrioma, that is probably something I'm also gonna ablate, because I'm not gonna start cutting out parts of the ovary. But other kind of what we call peritoneal implants, so implants that are in the lining of your abdomen, those typically I'm doing excision and cutting out and removing. So when I do surgery, I typically will do a complete survey of the abdomen and pelvis. So that starts with looking in the upper abdomen. So I'll take a look at the diaphragm. and the liver, the gallbladder, and the stomach all look at the entire upper abdomen. The diaphragm is an area where we sometimes find endometriosis. So that's an area that I'm looking at. I will then also do a survey looking at the rest of the abdomen and pelvis, usually always looking at the appendix. That's another area that frequently we can find endometriosis, and we can remove the appendix at the time of surgery. So I do a full survey of the abdomen. I don't always, if it's in an area where I am not skilled at operating, like the diaphragm, that's something that I would typically document, and then we'd have to discuss, and you may need a specialized surgeon to remove diaphragmatic endometriosis. So I think I had it in a few slides back. The recurrence of pain symptoms is typically 40 to 45%. And so that's not, and that really in the research, they're looking at pain symptoms, not necessarily like, do we look back at surgery and see lesions there, but like, do you have pain? And so typically that's about 40 to 45% of people can have recurrence of endometriosis symptoms. All right. So thank you so much. Feel free to follow us on social media. I am at the Lifestyle Gyne, and Dr. Prabhakar, who is the owner of La Miranda Gynecology and Surgery, is at the Fibroid Doc. Thank you.